I was born and raised in Stamford, Connecticut. My parents were Nancy Spina Titano, and my father was Andrew Anthony Titano. All four of my grandparents were born in Italy. My mother's parents were born in Naples, and my father's were born in Sicily. My mother was a realtor, and she was also very active in the political arena. She was the elected registrar of voters for the Republicans in Stamford, Connecticut for over 20 years. She was also a trailblazer. She was elected the first female president of the state's Registrars Association. My father, on the other hand, he worked in the insurance industry. My parents always stressed the importance of education, and I remember my mother would always say that the best gift a parent could give their child was a great education to set them up for life. My mother and I would often read books together. I have one brother, and his name is Patrick. He was my best friend growing up, and we still are very close. He lives on Cape Cod. During my childhood, I guess I would have to admit that I was quite the tomboy. I loved taking butterfly and insect courses with my brother at the Stanford Museum rather than play with my girlfriends and play with our dolls. For my education, I went to St. John's Grammar School in Stanford, and then also went on to Stanford Catholic High School. I was active in student government and was co-captain of the cheerleaders. As long as I can remember, I always wanted to be a nurse, so my choice of a major entering college was an easy one for me. I attended Western Connecticut State College and graduated magna cum laude with my Bachelor of Science in Nursing degree. And I added here a picture from my college yearbook. After graduating from Western Connecticut, I went on to Yale University for my master's degree in maternal newborn nursing and also a certificate in nurse midwifery. Just as I always knew I wanted to be a nurse, I always knew that my clinical specialty would be obstetrics. So that's all I have ever done in my career, is obstetrical nursing. The year before graduating from Yale with my master's, I met and fell in love with my husband, Chuck. At that time, he was attending the U.S. Coast Guard Academy in New London, Connecticut. Well, the rest is history. We've been married for over 40 years now. Once my husband graduated from the Coast Guard Academy, we moved all around the U.S. One of our moves was to Boston, and so it was there that I took advantage of being near Boston University to go on and get my Doctor of Nursing Science degree. While we were living in the Boston area, our son Kurt was born, and then we moved to Michigan, where our daughter Lisa was born a couple of years later. We've been blessed with our two children, Kurt and Lisa. They are the greatest love of our lives and have given us the greatest joy in our lives. As children, Kurt and Lisa were quite the troopers, and they learned quickly to adapt to changing environments and schools due to the various places that the Coast Guard would send us. One of the many things we loved to do as a family was to go to New Hampshire or Vermont for ski trips. I much preferred cross-country skiing, while the rest of my family loved downhill skiing on the Black Diamond slopes, where I never ventured. My husband and I have spent many an hour in ice hockey rinks, as both our children loved playing ice hockey. Kurt was the first to play hockey, while Lisa was busy taking dancing lessons. Our son was on the varsity hockey team at Bishop Stang High School in Massachusetts. Once my daughter Lisa saw her brother playing ice hockey, she knew that's what she wanted to do too. For high school, Lisa attended Portsmouth Abbey School in Rhode Island, where she did play varsity ice hockey. Lisa went on to play Division I ice hockey at the University of Connecticut. Here's a photo of Lisa at her graduation from UConn with her brother Kurt by her side. How exciting it was for me to be able to give Lisa her degree at graduation. I've now been at University of Connecticut for 20 years, which is by far the longest time I've ever been at one university. I teach mainly in our PhD program, and the courses I teach are qualitative methods courses and mixed methods research design courses. Soon after I started teaching at UConn, Dr. Denise Polite approached me to see if I was interested in being the new co-author of her classic nursing research textbooks. Of course, I was thrilled to accept her offer, and from then on we've been publishing together 2 American Journal of Nursing award-winning nursing research textbooks. I love writing and have published 2 books on postpartum mood and anxiety disorders. My co-author for both of these books was Dr. Jean Driscoll, who's known internationally for her clinical expertise in this area. Our latest book on traumatic childbirth has a 3rd author, Sue Watson, who's chairperson of Trauma and Birth Stress, the charitable trust in New Zealand. Sue Watson has been instrumental in helping me to recruit mothers for our studies on traumatic childbirth and its resulting PTSD. I've gone on to edit the Rutledge Handbook of Qualitative Nursing Research, and my most recent book is entitled Developing a Program of Research in Nursing. One of the greatest honors I've been fortunate to receive is being inducted as a fellow in the American Academy of Nursing. Another award that I was honored to receive was the Association of Women's Health, Obstetric and Neonatal Nursing Distinguished Professional Service Award. In 2007, I reached the pinnacle of my academic career by being named a Board of Trustees Distinguished Professor at University of Connecticut.
Well, Cheryl, I'm so glad that you've agreed to do this interview, and I know that the viewers are going to be so interested and excited to hear about your work. I found it very exciting just looking through and getting ready for this interview. And if you don't mind, I'm going to call you Cheryl.
Yes, please do. Thank you. This is quite an honor to have been asked to be in the 3rd volume.
Well, it's my pleasure, and you can call me Martha.
All right. That's a deal.
Okay. And as we begin, I think probably the easiest way to start is for you to give us an idea of how this all got started and then how it's evolved over time.
All right, sure. Well, my postpartum depression theory, teetering on the edge, it really began from clinical practice. And that's where I find the best research and theory comes from clinical practice. So in the early 80s, when I was practicing, I'm a certified nurse midwife, and I could see how devastating postpartum depression was for new mothers. And I wanted to really make sure that I was giving the best care possible to my mothers, so I went to the medical and nursing textbooks to read up on postpartum depression. But what I found were only a couple of sentences per book. So it was then that I decided to really devote my research career and theory to postpartum depression. And that's how I got started there. And then it continued on, because as more research had been done, we realized that women experienced a range of postpartum mood and anxiety disorders after birth. And there wasn't just postpartum depression. There was postpartum onset panic disorder. Latest now is PTSD, post-traumatic stress disorder, due to birth trauma. And how I got into broadening my area and developing my second theory on traumatic childbirth was really serendipitous. I was at the right place at the right time. Nothing that I had planned.
A lot of career developments like
Yes.
that, isn't it?
I had been invited to give a keynote address in Christchurch, New Zealand, to the Marseille International Society, and they wanted me to speak on the range of perinatal anxiety disorders, but to focus in on a study that I had conducted on postpartum onset panic disorder. While I was reviewing the literature for that keynote, because I wasn't up to date on all the anxiety disorders during pregnancy and postpartum, I came across just a few articles on post-traumatic stress disorder due to childbirth, and that was in the year 2000. maybe 4 or 5 articles at most. So luckily I mentioned that in my keynote, and after I spoke, a mother spoke who had experienced traumatic childbirth and went on to be diagnosed with PTSD. And her name was Sue Watson, and she helped to found a charitable trust out of New Zealand called Trauma and Birth Stress, in shortened TABS. And after she spoke, and it was very powerful reliving of her traumatic birth, at lunchtime we talked and decided that a project of mine could be to start to research women who've had traumatic births. So with her help, my recruitment notices are put up on their website, Trauma and Birth Stress, and that's how I have recruited mothers into my studies. And so that's one of my newer theories is traumatic childbirth, and I call it the ever-widening ripple effect. Because what I'm finding now is that just a few moments or hours in labor and delivery, which women perceive as being traumatic, leads to a series, these ripple effects, not different ways in their lives, their partners, and I'm expanding now into actual clinicians, secondary traumatic stress, because of being involved with traumatic births.
Oh, okay. Wow.
So 2 different ways, both clinical though, that I got involved in these theories.
I was interested as I was looking at, excuse me, some of your material, that things that have been in the past diagnosed as depression were probably not depression.
Correct. We used to, before we had more research on it, postpartum depression was the umbrella term that was used, and didn't realize that there were these anxiety disorders also. And so I've had women in my studies who were misdiagnosed as having postpartum depression, but when in actuality it was PTSD due to traumatic childbirth. And one of my first studies on traumatic birth, I entitled it Birth Trauma in the Eye of the Beholder. Because what I found was like beauty. A view of traumatic childbirth is just, it's all in the eyes of the beholder. And most of the time, I think if we were to look at a labor and delivery chart of women who've been in my studies and diagnosed with PTSD, a clinician would never dream that their birth was so traumatic that they could develop PTSD. But it's all from the viewpoint of the mother that matters.
Well, that's really interesting. Now, you did a study that was a nationwide study with other colleagues, I believe. Say some that out of that came this work, or clarify that for me.
That was a study, that nationwide study that was done with Childbirth Connection out of New York, and Harris Poll was involved in it, and so it was a nationwide study, and it was a quantitative study. And we used my postpartum depression screening scale that I have developed with Dr. Robert Gable, also at UConn, and we also looked at post-traumatic stress symptoms in women nationwide. And so what we found, having to do with elevated post-traumatic stress symptoms, that 9% of the women that participated in the study, and they were in the United States, there was almost over 1,500 women, 9% screened positive. Not diagnosed, but screened positive for having high enough symptoms of post-traumatic stress disorder that they should be referred.
Wow. Well, that's really interesting. And I at first, when I looked at your work and I saw you were using PTSD, I was a little bit surprised because, and a lot of people would be. That's why I wanted to be clarifying that, because I think people associate that with the military and people coming back from the military, although I know it has a much broader application, actually. And now, was that your idea to put that together, or how did that happen?
The PTSD.
Yeah, that it's.
It was out in the literature,
Okay.
certainly, but only in the year 2000. Only about 4 or 5 articles talking about PTSD in new motherhood.
Oh, it
because
was.
of the traumatic birth.
Oh.
But no one had done any qualitative research on it.
Okay.
So that's I've done about 6 or 7 studies now over the internet with women
Mm-hmm.
about traumatic childbirth.
Mm-hmm.
And so the first one was the one, what I really wanted to look at was what was it about birth that could be so traumatic that a woman could develop PTSD.
Yeah.
And so that, as I said, was called In the Eye of the Beholder.
Oh,
But it was
okay.
very interesting. What I found was that, yes, a couple of women did lose their babies. So certainly that is
Mhm.
traumatic. But for some, what it was, I think, is that they were systematically stripped of protective layers during labor. They were not cared for. They didn't feel cared for. They didn't feel like they were individuals. They weren't communicated with.
Mm.
And for some of them, they said they were stripped of their dignity,
Mhm.
that it was a very dehumanizing experience.
Mm.
So that was, for some of them, the reason they didn't. The DSM-4 back then when I started had said PTSD, the stressor would be that someone feared for their own life or that for someone else. Well, for some of the women in my studies, it wasn't that they feared for their life or their unborn child, though some did.
Mhm.
But it wasn't that for some of them. It was being stripped of their dignity,
Okay.
the lack of care during labor and delivery.
That, I think that's just fascinating. What struck me as you're going through those characteristics is that nursing can respond and should respond to all of those.
Yes.
I mean, we can do something about that.
Absolutely,
Uh-huh.
absolutely. And many times I've asked to speak to undergraduate nursing students
Mhm.
in maternity nursing courses. And I remember from when I did do that clinical with students in labor and delivery, they always felt like they really didn't have much value. They couldn't help the mother because they didn't know all the physical skills.
Mhm.
And I share the results of the research with them, and I'll say, you never know how many women you may have prevented
Yeah.
from viewing their birth as traumatic because you're right there with them. You're
Mhm.
caring for them, you're treating
Mhm.
them with respect.
Talking to them.
Absolutely. And adding those protective layers.
Yeah. Uh-huh. Uh-huh. Well, that's really interesting. Now, I would like for us to talk about how we certainly are talking about its use in practice,
Mhm.
but we're also talking about research and administration. So can you talk about how it's being used maybe in some different places, in different ways through maybe education and
Certainly,
Okay.
certainly. I can address both, well, the postpartum depression, and then it evolved into
the
the traumatic
Yeah.
childbirth. Well, in research, I have developed a postpartum depression screening scale, and it's being translated, at least to my knowledge, it could be more, but at least 14 different languages.
Oh, wow.
So it's being used worldwide
Uh-huh.
in clinical practice. It's been translated into Chinese, Hungarian, Spanish, Turkish, Portuguese, to name a few.
Mhm.
So that's being, my screening scale coming from the theory is being used in clinical practice throughout the world. It's being the theory, the
Mhm.
postpartum depression, the teetering on the edge, the information from it is being used prenatally so that, for example, clinicians are educating women in pregnancy about possible postpartum depression, the symptoms that are involved. Certainly postpartum, it's being used clinically like that.
Mhm.
In newborn intensive care units now, we know that those mothers whose infants, either preterm delivery or whatever reason that the infant is in the NICU, have a higher prevalence of postpartum depression. So, for example, University of Oklahoma Health Science Center is using the PTSD, my screening scale, throughout their NICU to screen women so that they could be identified for postpartum depression.
Oh,
and then they can start some interventions.
Mm-hmm.
In research that I have done on postpartum depression, I've also done some meta-analyses looking at predictors of postpartum depression. And from that have developed postpartum depression predictors inventory, and that also is being used around the world to identify women who have a higher level of risk factors for developing postpartum depression. And this way, hopefully it's being instituted prenatally so that we can start interventions before they even give birth, so that maybe we can prevent postpartum depression, or at least start having the treatment early enough that it won't get to a severe enough level. Because we know now some of the predictors are elevated levels of depression in pregnancy, elevated anxiety in pregnancy, poor marital relationships, things like that. Those are types of risk factors that should be identified prenatally and then start some interventions.
Now, the instrument, I just need to clarify again, the instrument, did it get updated after the 2002, well, or whenever you did the national study?
The 2002 is when the screening manual was published.
Okay.
And so it was completed before the national survey.
Okay.
The instrument I developed with Dr. Gable all of the items from my series of qualitative research studies with mothers on postpartum depression, from the Teetering on the Edge postpartum depression theory, so that all the items on it are phrases women have used repeatedly in my interviewing with them, so that they identify really well with the items on the scale, because they're words that mothers would tell me all the time.
Okay.
And the scale has 7 dimensions, so it taps 7 different symptoms that women can experience during postpartum depression. For example, some of them are items that other depression scales don't have. And in any type of a screening scale, you have to have items on it. It has to cast a wide enough net.
That's right.
Because we know there's an array of symptoms that women with postpartum depression can experience, but not all women experience all of them. But if you don't have a screening scale that taps that range, we may miss someone. For example, loss of self was one of the dimensions. Women talk about in postpartum depression that they don't know who they are anymore. They're like an empty shell, a zombie. They're not the same woman that they were before the depression hit. Anxiety for some women is much more of a problem than the depression, so that some depression scales don't tap anxiety. So I have 7 different dimensions that taps.
I think a strength of your work is that you worked with Dr. Is it Gable? And did quantitative testing of qualitative findings.
Yes.
Which a lot of people don't understand the importance of that, but it's highly important in knowledge development, because anyone could say, well, yeah, that's what you asked those people, and you had just a group of people, and that might not be in these people from another state or whatever.
Correct. Correct. The marriage of qualitative research with instrument development really is coming into the forefront. That qualitative research results really the way to get your items.
Well, we certainly can ask things or study things that were very hard to get at, or we couldn't get to them maybe even with quantitative, just a quantitative manner.
Correct.
And the depth and the strength of qualitative is the depth and the what it's very natural, like you were saying, that it's what they are experiencing.
I like to view qualitative research as bringing visibility to invisible phenomena, like I've done with postpartum depression and then traumatic childbirth.
Yeah, yeah.
Because my series of studies on traumatic childbirth have brought into the light that not only that really birth trauma, just a couple of minutes or a couple of hours during labor and delivery, has long-term chronic potential effects.
Oh, okay.
I've done studies on the anniversary of birth trauma, which I call failure to rescue, because anyone who's been diagnosed with PTSD, say men and women who survived 9/11, any anniversary of your trauma is a flare-up of symptoms, and I would think that someone, family or friends, would be calling survivors of 9/11 every September 11th and saying, you know, I know this is a hard day for you, we're here for you, you want to talk, you know, want to have dinner together, I'm here. But no one does that for these women. And that's again the beauty of qualitative research, bringing it out into my theory, is that I called it failure to rescue, because women shared there was not just the one day itself of the anniversary, which was difficult, but weeks, sometimes months leading up to it, and then there's an aftermath to it. But the anniversary of their birth trauma is always a day of celebration. It's the child's birthday. And so mothers obviously want to give their children the best birthday, happy day they can, but they really struggle through it. And so the qualitative research is bringing that into light. Subsequent childbirth.
Yeah.
Another study that I have done that's incorporated into the traumatic childbirth theory is that those 9 months was very panic-filled for these women, because they have to wait to get to what they fear the most, is another labor and delivery.
Wow.
It also impacts breastfeeding. That was a study that I've done with Sue Watson, the mother from TABS, and found that the impact of birth trauma on women's breastfeeding experiences, we call it a tale of two pathways.
Okay.
Because one pathway, it's almost like women, we talk about making lemonade out of lemons. They've had a traumatic birth, but they use that to propel them to breastfeeding through no matter what. Women talk about that they felt that they brought their child into the world in a very, traumatic way, and they have to make up for that. They feel like they were failures as women, as mothers. And so they said, what else could I do to prove to myself and others that I could do something right with motherhood? And that would be to breastfeed. So some breastfed for almost 2 years. And they talk about making up atonement to their infant for and they use the term mortal sin for the way the baby was birthed. But the other path, which most of the women took, was very detrimental to breastfeeding. Some only breastfed for a day or two, because one of the reasons was that in traumatic childbirth, if I had to use the one image that the women told me the most since 2000 doing this research, is that they felt raped on the delivery table with everybody watching and no one offering to help. So they felt violated. And so breastfeeding, they didn't want another part of their bodies ever having the possibility of being violated. So some women never breastfed at all. So many, that's why it's starting, I call that theory the ever-widening ripple effect. Because seeing more and more of those negative consequences to women.
Well, and your work is known, as we just were saying, and used globally. I wanted to ask you, there's a website that when I searched on your name way back when I knew that I was going to invite you, or maybe had already invited you, I don't remember. But anyway, there's a website, I think it's in California, and it's incredible.
Postpartum Support International.
Okay, okay. Well, you need to say something about that for our viewers, I think.
It's an excellent organization. It's obviously international, and its whole mission is to bring understanding, treatment, and prevention for the wide range of postpartum and prenatal mood and anxiety disorders that women may experience due to childbirth. I'm on their President's Advisory Board right now. You asked about the implications of my theories for education, and Postpartum Support International does training, mental health training for childbirth disorders worldwide. And they have training sessions, like 2-day training sessions.
For nurses or for
nurses,
mothers? Or?
No, any type of clinicians, physicians,
okay.
nurses, social workers,
Okay.
physical therapists, people who are interacting with women during the childbearing cycle. And so they have 2-day training sessions, and they have incorporated my postpartum depression work and now the traumatic childbirth work of mine, the theories, into their training.
Oh, okay. Well, what impressed me was it right away on that site. It's almost like there was a place for me to click. I think I might have just been looking for your information to contact you. But anyway, there was this place that I could click, and it was like it was assuming I was a pregnant woman looking for help, but there would be help immediately.
Absolutely.
That was just impressive, you know.
The training is for healthcare professionals, but a tremendous part of that Postpartum Support International is support for women and their families. They are so extremely organized. They have state coordinators in every state in the U.S., and it's on their website. So say if a mother in Ohio was suffering from what she thinks is postpartum depression, wanted to know if there were any support groups in her area, she could look on that website, look under Ohio, and would be given the name, phone number, address, email of the state coordinator, who are all mothers who have survived perinatal mood or anxiety disorder and call. They have hotlines for the mothers. They have for fathers, hotlines for fathers. They have periodically in the month, they have where you can call and talk to an expert, a psych mental health expert in perinatal mood and anxiety
I think I
disorder.
saw that.
A tremendous wealth of information.
Oh yeah, it's a very impressive site, and I think it came up right away when I put your name in.
Jane Honickman was the founder of
okay.
that, and she lives in Santa Barbara.
Okay.
And she really was one of the influential people in my life because I had started with researching postpartum depression, and would have me there to give some lectures, and they have a conference every year. And then she would say to me, Cheryl, you've got to get international. You have to get international with the Marseille International Society. And so with her help, then I moved on to the Marseille Society and was on their executive board for a few years.
Okay, well, so what would you consider your most important contribution? And I know you're still working and doing research.
I know. I don't think I'll ever retire. There's not one. Certainly the postpartum depression theory, my teetering on the edge, started as one grounded theory study. Identifying loss of control was the basic problem in women's lives with postpartum depression. Loss of their emotions, their thought processes. There was nothing that they could control. And I, in that grounded theory study, identified the 4 phases women went through.
Oh, okay.
And so the first was encountering terror, which were those really suddenly hit with all of those distressing symptoms. Then the second phase I call dying of self. That's the loss of self. And then literally some women trying to end their own life. The third phase was struggling to survive. And then the fourth was regaining control again. And in that regaining control, one of the key pieces that came out was that, yes, the depression had lifted. But now as clinicians, we still need to concentrate on these women, because what came out was that they were mourning lost time. There was grief work we had to do with them because the title of the theory was called Teetering on the Edge, which really the women talked about in the worst of their depression. Every day they would walk a fine line between sanity and insanity. But once the depression lifted, they can now look back and see the time that they have lost with their babies that they will never get back again. So there's grief work involved. I've modified that theory twice because in grounded theory, I use Glaser and Strauss's classic method. And you always modify a theory. And so what I have done is I've taken qualitative research done by other researchers in different countries and added that in because my original theory only really came from middle-class Caucasian women. And so I have expanded it, included data from 27 other countries.
That was interesting. How did you do that?
Well, you get the data from the studies that were done by other researchers, and I was looking for women, different groups of women. I wanted to expand the scope of my postpartum depression theory. And so studies had been done, for example, with women from Ethiopia, United Arab Emirates, the Democratic Republic of the Congo, Taiwan, Sweden. And so what I did was I looked at, are the symptoms the same, or are there anything new that I should add to my theory? And there was one thing that I did add, and under the first stage, which is the encountering terror, the symptoms, what I found in some of these other countries is the somatic symptoms that weren't included in the original theory. For example, women with postpartum depression talked about tiredness of their heart, a heavy heart. They talked about weakness in their arms, body ache, stomach ache, so that there's a lot of bodily more symptoms than really in the original one. So that if people are going to screen in those countries, they need to be using some of those terms. So that's so I've modified it twice. So obviously the postpartum depression theory is I consider one of my best accomplishments, and then also the newer, the ever widening ripple effect, which I told you about some of the ripples. You know, the anniversary birth trauma, the subsequent childbirth, the breastfeeding. And then what because when I would present the traumatic childbirth studies, and sometimes there were nurses in the audience, and in the question and answer period, they would say to me, Cheryl, you should investigate us. These are labor and delivery nurses. We're as traumatized as the mothers. So again, everyone helping me develop my theories, the labor and delivery nurses then directed me, to think about this. So I went back to the literature and found what's called secondary traumatic stress. And it's in caregivers. And it's different. Most of the research started with psychotherapists and social workers working with child sexual abuse survivors, where you are continually listening to these stories over and over again, giving care to traumatized patients. And so I looked, and nothing had been done in the area of labor and delivery or with certified nurse midwives on their secondary traumatic stress. So I've done 2 mixed method studies that recently, they're in press now, looking at secondary traumatic stress. And for example, over 24% of the labor and delivery nurses in my study, and there was over 500 of them, screened positive for high level of PTSD symptoms. So that's something new that. So that whole the area the ever widening ripple effect is another one. And I guess the last accomplishment is a book that I've just published, and it's called Developing a Program of Research. And so I've used my 30 years or more of research and showing my thought processes between bouncing back and forth between qualitative research, quantitative research, mixed method studies, and just to instruct on developing a systematic program of research.
Mhm.
Because what I found is there's numbers of books on how to write a successful grant, but there wasn't anything out there on how to develop a valuable systematic program of research.
And is that, now I happen to know you're doing page proofs in the last day or so. So is that book?
No,
That's something
no,
else.
Yes, no, that the developing a program of research in nursing came out, I guess, about 6 months ago.
Oh, okay.
No, the one at Page Proofs is on writing with Dr. Thomas Long, and it's a series on writing in different disciplines. So obviously our book is writing in nursing.
Mm-hmm. Okay. So he has chapters on different disciplines.
The editors do.
Oh, the editors.
Yeah, he and I are just for this one particular book.
Okay, all right.
No, there's writing in biology, writing in engineering.
Mm-hmm.
So ours is just.
But he's with you in the nursing one?
Yes.
Because his expertise is in writing?
Yeah, English. His PhD is in English.
Okay.
Yes.
Okay.
Mm-hmm.
Well, that should be really interesting too and useful.
Mm-hmm.
So you're working on a chapter?
No, it's the whole book. The two of us together did the whole book.
Oh, okay. Okay. Well, that's very interesting work. Well, I want to thank you for consenting to do this interview, and I know the viewers are going to be so thrilled. A part of this series, this volume 3 of the portraits, Nursing Theory Portraits of Excellence, has an emphasis on practice, and your work was born in practice and has grown in practice,
yes, it has.
Even though you're a researcher. And I think that's an important lesson for the nurses and students who will view this as well, is that, yes, practice and research and theory all go right together.
Absolutely. Thank you very much. It's quite an honor to have been chosen.
It's been my pleasure. Thank you.